and the great folks involved in the Washington Public Health PBRN have agreed this month to give us some updates from research that's happening within their network, and so I think we're really in for a treat today. I know that the folks there in Washington are really going above and beyond to actually be able to make our meeting today. As many of you have probably heard, the Northwest is getting hammered with a rare snowstorm, and so thanks to our colleagues in Washington and in Seattle in particular for finding a way to join us today. I believe that we'll hear from a couple different leaders and scholars within the Washington PBRN. Laura Hitchcock, who is the coordinator and in many ways ringleader of the Public Health PBRN, I think is going to start off. Laura, I think, is well known to folks involved in the Public Health PBRN program. She's with the Public Health Seattle and King County agency, which is the kind of the hub of the Washington PBRN. And I think we'll be hearing from her, as well as Dr. Anthony Chin, who is director of the Tacoma-Pierce County Health Department, and also a very active member and leader within the Public Health PBRN on the executive committee, PBRN executive committee for the Washington PBRN, and has been playing an active role in a number of the research projects underway. And I think we'll also hopefully hear from Tina Abbott, who's a human resource analyst with Public Health Seattle King County, and is active in another one of the studies underway within the Washington PBRN related to QI around diversity and hiring practices, testing a very interesting intervention to improve diversity in hiring within public health settings. So that's our lineup for the kind of research in progress component of the agenda today. And I believe I'm going to advance slides for your team. Is that right, Laura? Is that our plan?
Yeah, that would be great. Thank you.
Fantastic. So with that, let me turn it over to Laura and the rest of the Washington PBRN team.
Good morning, everybody. This is Laura Hitchcock, and we appreciate the opportunity to be able to give an update from the Washington Network. I know you've heard quite a bit about the FAST study in the past, and I know that Betty's on the phone today as well. So we thought we might give you a little update on some of the other projects that we're working on, because we are working on a whole variety of different things. So we wanted to have you get a sense of some of the other things that we're working on as well. So I'm going to, hang on a second, I'm going to step away. I'm in my husband's office because we have a massive snow and ice storm going on right now, so sharing office space. So one of the things that we thought we might try to do today is with our first presentation, which Dr. Chen is going to give you a little bit of a sense of how we've tried to move research from the initial phase through translation. We are doing some interesting translation work, and so he will talk a little bit about that with a project that we've been working on. And Glenn, you can go to the next slide, please. This is a map of our network, give you a sense of who has been present. We have a fairly active executive committee. We are going to quarterly executive committee calls starting this month. We're actually entertaining the idea of trying to have a research incubator call where researchers from around the state who may or may not be on the executive committee but who are interested in PHSSR would have the opportunity to discuss and debate ideas about different research projects. Okay, next slide, please. So for our Washington PBRN, we went through a process, I think as many of you have, of identifying what the areas were that we were interested in looking at. In 2008, did a survey of different partners around the state, and were able to then come away with some specific areas. And I want to just briefly touch on what some of these areas mean in terms of some of the thinking we've done around different possible research topics. For system organization, we've thought quite a bit about looking at what the impact of different laws are. We have put together a couple of proposals on impact of change of laws. We are interested in system governance. We're really interested in Board of Health activities, systems development, as well as community partnerships and community organizing. For funding, obviously with a lot of the work that we're doing as part of FAST, very interested in what the impacts are of budget cuts on the public health system and also understanding revenue streams. And just recently had an opportunity to present to our state and local public health officers association about shared services and looked at some of the research that was done around the country by other PBRNs and presented that so that they would have a sense of how other states are looking at shared services and how to optimize best arrangements for shared services. For staffing, we're very interested in workforce diversity, workforce capacity, and what the impact of staff cuts is in particular on diversity and health disparities. We have a project going on in that area right now. And then finally, under delivery of services, we're really interested in variation in practice, and a number of our studies reflect that. Next slide, please. And so you should be able to see here what the various studies are that we're working on. We're going to focus today on the ones that are highlighted in sort of orange. We have several completed studies, as I noted, a number related to variation in practice. And then the studies that we have underway, obviously participating in FAST, and then we have a quick strike grant to do work around quality improvement in workforce hiring, which we're going to hear about. And then we also have a recent grant on the impacts on workforce diversity, on, workforce cuts on workforce diversity and health disparities. And that project is just underway recently. Next slide.
Good morning, everyone. This is Anthony, and I'm going to talk about a series of studies that comprise the first study of the Washington Public Health Practice-Based Research Network and where it is leading us. And you can see on this slide the list of the people who are involved in the study. Next slide, please. So this is based on something which Glenn talks about a lot, the PHSSNR PBRN research continuum. And as it was originally envisioned, this study was intended to be in the descriptive and inferential phase on this continuum. Next slide, please. Here are the objectives of the H1N1 project. They were to assess variations in H1N1 preparedness and response activities across local health jurisdictions, describe lessons learned that could be applied in future flu pandemic or other public health emergencies, pilot and describe a method for real-time evaluation of a public health emergency. Next slide, please. So the details, the study itself was conducted by Public Health Seattle-King County on behalf of the PBRN at the request of the Washington State Department of Health. 4 phone surveys were conducted and 2 online surveys with health officials from 15 local health jurisdictions between September 2009 and May 2010. As a reminder, in case any of you have forgotten, H1N1 showed up in April of 2009, and DOH and the PBRN, as well as many other people, became very interested in what was going on because we had a natural experiment here. And so over the summer, it was quite quiet as everyone's preparing, and then the real peak of H1N1 was towards the end of October, and then from there kind of tapered out. So the surveys and conversations with officials occurred kind of in the planning stage before the big surge, and then during the peak incidents and as it tapered out, and then followed into the debriefing after action reports after the end of the H1N1 epidemic. The findings of each survey were reported to the stakeholders, and then a final report systematically reviewed and compared the findings from each topic across all surveys. This was funded by CDC through a cooperative agreement, and of course with the support of the Robert Johnson Foundation funds through the PBRN. Next slide, please. To give you an idea, our state is broken up into 9 regional emergency preparedness areas. So the participating local health jurisdictions, there was the lead agency from each of these 9 areas, and then in the regions that had more than 3 local health jurisdictions, we chose 1 additional local health jurisdiction. And for those of you not familiar with our 35 counties, you might be able to read the fine print on the lower slide that tells you the names of each of the counties. Next slide, please. I'm going to go through and give you a sample of some of the findings. If any of you are interested in seeing the whole summary document, let Laura know, and she can send you a PDF copy of it. But I'm just going to give you some highlights. So in the area of vaccine distribution, administration, and tracking, it was pretty clear that most locals were unable to estimate vaccine coverage in the ACIP target groups. And therefore, a timely and efficient statewide vaccine reporting system is needed and should be used to inform decisions about target group prioritization and other vaccine strategies. Next slide, please. In terms of impact on local health jurisdictions, I think many of you can identify with these. Additional federal funding was essential to the success of local response. It was still challenging for local health jurisdictions to maintain routine public health functions while the emergency was going on. Funding was needed to incorporate lessons learned into local preparedness plans. Incident Command System, or ICS, is useful to organize response but difficult to maintain for a long time period. And there was a need to adapt ICS structure to meet long-term needs. Next slide, please. The piloting of methods for real-time evaluation, the methods were really not timely enough for providing real-time input into outbreak management decisions. And there are some recommendations by using simpler online surveys and development of other formal mechanisms to provide real-time input. Next slide, please. And in terms of use and usefulness of findings, it was general agreement that it was very helpful to be able to document local health jurisdiction activities, experiences, and opinions, especially when everyone was busy trying to survive the incident. And it also allowed us to identify system-wide issues, which would then eventually inform local and statewide improvement plans and preparedness planning. Next slide. So what we find really exciting is that what this study led to was that while it originally was planned to be descriptive and inferential, allowed us to move into the translational phase of this continuum. Next slide, please. So on our PBRN translational phase, we kind of batted around some names for it, but we kind of landed on this concept of a flexible continuity of operations plan or planning. So based on the lessons, just to remind you, in the earlier slides, everyone felt that ICS was useful to organize the response. However, ICS is intended for physical disaster response and kind of very severe acute emergencies rather than ongoing epidemics like H1N1. And even in our epidemic or pandemic planning, H5N1 is much more severe than H1N1 is. So this showed us that we needed to revisit how we do our emergency planning. And while ICS was useful, it was difficult to maintain for a long period of time, primarily because it was challenging to maintain routine public health functions during ICS activation. And therefore, there was a need to adapt the ICS structure for incidents of variable severity and duration. Next slide, please. Here's a graphic that we borrowed from ASTO, and as I mentioned, most of our emergency plans are written for these short, severe emergencies, such as earthquake, and so something depicted by, say, the blue line in this graphic, in contrast with emergencies such as H1N1, which fluctuate like the red line in the background. And interestingly, in the ASTO graphic, the horizontal axis, they put weeks, but in H1N1, we were talking months, about 10 months or so in that whole incident. Next slide, please. So some details about the next phase of where we're taking this project. The next part was conducted again by Public Health Seattle-King County on behalf of the PBRN at the request of the State Department of Health. They set out first to review the literature on ICS and COOP, reviewed the federal, state, and local after-action reports, and conducted phone conversations with Department of Health staff, a selection of small, medium, and large local health jurisdictions, as well as Pierce County Emergency Management. Next slide, please. The product was it's officially entitled a Continuity of Operation Plan and Incident Command System Guidance Handbook. And it aims to review the best practices in ICS and COOP in Washington local health jurisdictions during H1N1, and then provide step-by-step planning for ICS and COOP and sustained incidents of varying severity and duration, or what we're going to call flexible COOP. And basically prepares local health jurisdictions to flex up and flex down to address demands of emergency, incident, and routine public health functions. Next slide, please. To give you an idea, here are the steps that are being recommended to develop a flexible COOP. First of all, you want to sit down and inventory all the services, programs, and functions that your local health jurisdiction performs. Second, you want to review or develop your ICS. In other words, go back and look through what works, what doesn't work, and what you have in place and training that's in place. Next step would be to develop categories of severity and duration of emergencies. And then what you have then is then you would be able to, for each category of emergency, prioritize the services, programs, and functions for that category, anticipate the scale of ICS activation that might be needed, and as well identify staffing, lines of succession, legal issues, resources, and so on to support ICS and COOP. Next slide, please. You know, I think we're off one slide. So, okay, so now we're up to project status. So this is where we are in the project. The COOP and ICS guidance handbook was delivered by the PBRN to BOA. Sat on it for a few months while they looked it over. And so in the past month or so, Department of Health has distributed this handbook to select local health jurisdictions for comments. Next slide, please. In terms of where we want to go, and unfortunately it's not clear whether there'll be funding to take the next steps, but here's what they would be. We would like to see that this handbook is revised by based on feedback from local health jurisdictions in terms of readability, applicability, feasibility, and so on and so forth. And then after it's been revised, that some local health jurisdictions pilot test it to try and develop flexible COOPs. Once that's done, then of course you would want to go back and evaluate the feasibility of the intervention and quality of the guidance, i.e. the handbook, and maybe revise, you know, whatever plan there is, that, or whatever flexible COOP you have. As it stands, the state is planning or has planned a statewide exercise in July of 2012, and we hope to be able to incorporate the flexible COOP during that exercise. In other words, while there's the whole statewide exercise, we're hoping that they would be willing to modify the exercise a little bit so that it does go through you know, it exercises on tabletop a duration of time as well as builds in this fluctuation in severity. And those LHJs that have agreed to pilot their flexible COOPs will actually try and exercise their flexible COOP while they're doing the state exercise. And of course, after the exercise is completed, you want to evaluate again the feasibility of intervention, quality of guidance, and then that will go into revising the handbook and allow you to broadly disseminate it. As you can see, this is really moving into a different kind of research. It's not just observing what's going on and describing what's going on. It really involves developing interventions, evaluating and revising, pilot testing, again, evaluating and revising, going to broader testing, going back again, evaluating the process and the outcome, going back again, refining, and then broadly disseminating. So whether you want to draw analogies to quality improvement like PDSA cycles, or much more in the realm of health education, program planning and evaluation, but this is going to require a different set of approaches and skills and obviously funding sources. Next slide, please. So to go back to this graphic about the PHSSNR PBRN research continuum, you can see how we move through the descriptive, inferential, and translational phases. We're still trying to move through that last phase, and we'll keep you updated in the future. That's it for my section. So, Glenn, did you want to pause for questions, or did you want to pause for questions at the very end?
Good question. What's your preference? Do you want to take some questions now?
I don't care either way. I guess it's kind of up to the audience whether they have burning questions or whether they can hold it.
Why don't we have folks, just to make sure we get through, we have got enough time, have folks hang on to your questions for now. If you have questions based on this, hearing the update about this first study on H1N1, hang on to them, and we'll proceed through these next couple of sections and then have a chance to take questions and general discussion.
Okay, this is Tina Abbott. Can you hear me okay?
Just fine.
Okay, I think Laura's been dropped. So
I'm back on actually now.
Oh, great. Do you want to introduce this?
Yeah, sure. So Tina Abbott is on our project team for the Quality Improvement Equity and Hiring Project. And this is funded, this particular research project is funded by RWJ as a quick strike. And so it's been really interesting. I think Tina's going to talk a little bit about how the quick strike fits into a broader initiative that we have going on at Public Health Seattle and King County around equity in hiring specifically, and maybe a little bit about how that came to be with respect to initially an initiative and now an ordinance that we have in place in our county around equity and social justice. And I wanted to mention also, by the way, that the PI for this project, because I think many of you know her, Dr. Nadine Chan, had a baby boy in December. So she's not with us today because she's at home on maternity leave. But I know would be very delighted to learn that we're presenting this update. And we are just partway through this project, so it's an update today. We also have Kate Neville on the phone with us. She is our Quality Improvement Manager at Public Health Seattle and King County and was involved in some of the QI intervention work that we did to develop the intervention, and then some of the work carrying it out. So she can talk about that or answer any questions that people may have.
Okay, thanks, Laura. So my name is Tina Abbott, and I'm a Senior Human Resources Analyst at Public Health Human Resources. And with this project, we wanted to develop and test a QI initiative to improve the racial and ethnic diversity of our workforce. We focused on making changes to our hiring process in an attempt to eliminate unconscious or implicit bias. Next slide, please. And next slide again, please. Thank you. In 2010, Public Health Human Resources launched the Equity and Social Justice Quality Initiative Hiring Project. In 2011, this project became a departmental commitment in the King County Equity and Social Justice Interbranch Team's work plan. And we've provided a link for you here to the webpage on King County's equity work in case you're interested in exploring that further. The goal of the project was to establish best practices in our hiring process to increase the diversity of our workforce using QI methods and tools. We wanted to limit the scope so we could be certain that we knew which interventions were having a positive impact. Therefore, we didn't include recruitment, retention, or promotion in this project. Next slide, please. An analysis of 2008 data showed that in the aggregate, the workforce of our department reflected the racial and ethnic diversity of the King County population. We went on to analyze the 2008 through 2010 hiring data, which showed that hiring in the lower salary ranges was very diverse, while hiring in the highest salary ranges actually was not. The quick strike research was intended to support post-data analysis and to develop and evaluate the QI methods used to address the issue. Next slide. Our timeline for the Quick Strike project began in the spring of 2011 when we convened a team of stakeholders to do the QI work and began developing new hiring procedures and training materials. And at that time, we were going to begin a hiring manual as well. In the latter half of 2011, we were going to be implementing the interventions and collecting quantitative data. We were going to go on towards the end of the year to start analyzing the post-intervention data and comparing that with our pre-intervention data. And then this month and next, we would be presenting our findings, making recommendations for quality changes, and then later on this year, adopting changes in our practices and disseminating our findings. Next slide, please. what we found was that at the micro level, our workforce was not as diverse as the communities that we served. Next slide. Our research aims included conducting focus group interviews of the QI team to review the baseline data that we gathered and identify opportunities for policy and practice changes in the hiring process. We were going to develop quality improvement strategies based on literature review and the recommendations from the quality improvement team, and then implement changes via training of hiring managers and creating a hiring manual. Next slide, please. We were going to be conducting pre and post evaluation of the impact of the modified hiring processes by comparing the racial and ethnic composition of our new hires before and after the initiative. We'll be developing recommendations for hiring policies and procedures to improve the workforce diversity, and finally disseminating our findings. Next slide. We convened the quality improvement team and held group discussions on the research and the current practices we had at Public Health. We also reviewed the quantitative baseline data about our workforce, our applicant pools, and our hires. Next slide, please. The QI team also reviewed employment process maps, public health applicant and hiring data, as I said, a summary of the literature on bias, and then what you see here is we completed root cause analysis using the fishbone diagram and a 5 whys exercise. We then went on to generate a robust list of possible interventions using affinity diagrams and a prioritization matrix. Next slide, please. The data that we've collected and analyzed was looking at the racial and ethnicity of our staff and our hires as a whole, looking at the race and ethnicity of our staff and hires by classification, and then finally looking at the race and ethnicity of our staff and hires by salary ranges. The post data has not been, the post-intervention data has not yet been collected. We're just beginning that now. So what we have here is the data that we looked at prior to the intervention. Next slide. The slide that you see here shows a comparison of our public health staff compared to the King County population by race and ethnicity for 2010. And as you can see, the public health staff actually fairly closely matched the population of King County. And this has been fairly static. There's been a little bit of change in the diversity, increase in the diversity in the King County population over recent years. And the public health staffing has stayed about the same, but we've been in the ballpark for a while now. Next slide. For 2008 to 2010, what this slide shows is that we hired American Indian, Asian Pacific Islanders, and whites in a greater proportion than we were receiving applications for them. We hired African Americans and people who claimed 2 or more races at a lesser rate than we received applications for. Next slide, please. We went on to divide our job classifications into fifths by salary ranges. Quintile 5 are the lowest paid classification, and quintile 5 are the highest paid classification. As the salary increases, the percentage of applicants and hires that are Native American, Native Hawaiian, and Pacific Islander and multiracial decreases. In general, we hire individuals from these groups at a lower rate than they apply. Generally, the same is true for African American applicants and hires. The exception is the applicants in the fifth quintile actually increase a bit, although we hire at an even lower percentage, both overall and as a percentage of our applications. Additionally, we hire African American applicants at a lower rate than they apply. Next slide, please. I'm sorry, and next slide again, please. For white applicants and candidates, the opposite is true. The higher up the salary range we go, the more white applicants and hires we have. Additionally, we found that we hire white applicants at a higher rate than they apply, particularly in the highest paid quintile. Next slide, please. we originally had in excess of 50 potential interventions to close by the QI team. Using an affinity diagram and prioritization matrix, we eliminated interventions that did not directly address bias and organized them by feasibility and potential impact. The recommendations that we've listed here are those we felt would have the most impact and are the most feasible. So for 2012 and actually back into 2011, we'll be doing some disparate impact analysis for a sampling of our recruitment. We'll be developing a hiring manual or a best practices handbook that summarizes the literature review, the bias countermeasures that we've decided to take, and other techniques for hiring a diverse workforce. We'll be developing and implementing an organizational policy to promote accountability for employing a diverse workforce. Next slide, please. We've already begun to provide just-in-time training to interview panels on implicit bias and tools for countering it in the hiring process and the impact implicit bias has on the hiring process and its outcomes. We'll be originally recommending and then ultimately requiring interview panel diversity. And interestingly, the research that I was able to find suggested that racial diversity on an interview panel has a positive impact on outcomes, while gender diversity actually doesn't seem to have any impact at all. And then finally, we'll be recommending originally and then ultimately requiring the development of all selection tools, that is the interview questions, reference check questions, and any screening tools for candidate application materials are forwarded either for further screening or for interviews to hiring managers. Currently, we don't require that supervisors show proof that they have completed all of their selection tools before they see their final applicant. Next slide, please. So our status now is we have gathered the quality improvement team, which was comprised of hiring supervisors, program managers, and frontline staff, who reviewed the baseline data on race ethnicity of our staff, our applicants, and hires, and then went on to make recommendations for changes to our hiring practices and policies. We've implemented some of that training. We had originally, when the Pritzker was proposed, intended to have a control group using one of our divisions. Our thought was we would train one division and use them to compare to outcomes against the rest of the department. At that same time, excuse me. At about that same time, the economy changed fairly dramatically, and the division we intended to use as a control was laying off staff rather than hiring, so we didn't think we were going to be able to do this. In the last month, though, we had an opportunity to train most of the supervisors and managers in that division, so we'll be able to go forward with doing the comparison. We'll be developing a hiring manual or some other written manual of best practices this year, and we'll be conducting the pre-evaluation, actually the post-evaluation data analysis. Oh, there. So we've already done the pre-evaluation, and the next slide we'll be conducting post-evaluation data analysis beginning this month. Could you go to the next slide, please? Thanks. Recommendations for hiring policies and procedures to improve workforce diversity were made already by the quality improvement team, and we're refining the strategies based on literature review and the recommendations from the team to be implemented over the next 12 months, 24 months, and 5 years. And then we've already begun dissemination of the project. We've been providing variations on the training and presentations about the project throughout King County in recent months. Next slide. So what's next? Next slide. We're going to continue the implementation of the recommendations. We'll be measuring the impact on hiring outcomes for the fourth quarter in 2011 going forward for our post-data comparison. And ultimately, we'll be beginning another project using QI methods similar to what we've done here to look at our recruitment, retention, and promotional efforts in the department. Next slide. finally, the lessons that we learned. One, the first one that was a surprise to me was that the timeline for the completion of the project was overly ambitious, and we think this resulted in several factors. One was that the QI group that we worked with was actually fairly large, and convening that group on a regular basis turned out to be rather problematic. Two, we realized that while we were also learning about best practices in hiring and bias, we were having to learn about quality improvement methodologies and tools, and then finally how to apply those to human resources practices. And then extracting data from our web-based hiring tool is proving to be quite a bit more cumbersome than we originally expected. And then finally, drawing definitive conclusions as to root causes in terms of the outcomes that we were seeing in our hiring proved to be more challenging than we originally anticipated. And while we can say that we suspect that the root causes are personal bias and institutionalized racism, we can't draw a direct line from that to the outcomes that we are seeing. So we're having to operate on the belief that that might be the case and go forward and test out our hypotheses. So that concludes my presentation, and I'm happy to take any questions.
Fantastic. Thank you so much for our Washington PBRN team. So we are open for questions now, and so if you have questions, why don't we, if you got a question, unmute your phone and let us hear from you. And this will be for any of our panelists from the Washington team today.
Glenn, hi. This is Elaine from Connecticut.
Hi, Elaine.
Hi. Can you hear me?
Absolutely.
Okay. I had a question actually I have like two questions, but first for Tina, I just think the work you're doing is fabulous. I was just sitting here thinking this is so important for all of us, and I think my question is, when you look at the outcomes, I know there's a lot of emphasis on hiring practices, but are you also looking at issues of retention?
For this particular piece,
in the culture that people are working in and having a multicultural, multi-ethnic environment in the workplace, is that part of what you're looking at?
I'm sorry, I didn't hear the last part of your question.
The question was, I think your outcome measures are around changes in hiring practices so that you have more diversity in all regards in the organization, placement, people's status and so on, and positions that people are in, but are you looking at retention of a diverse workforce as well? As an outcome?
For this part, right. So for this part of the project, we're not. We wanted to make sure, one, that that the scope of the project was such that we felt confident we'd be able to complete it. And two, we wanted to be sure that we understood exactly how our interventions were having an impact on our outcomes. The next phase of this project will be to look at both retention and promotion opportunities within the department and the recruitment phase of the hiring process. So this has really been focused on the middle phase, and later on this year we will begin to initiate looking at those both the early phases, the outreach to the community, and then outreach and what we can do in the department to retain a diverse workforce and to promote from within as well.
Thanks. And I think that there are public health training centers that are doing trainings around quality improvement that would be interested in the training that you did. So perhaps we could talk offline about that sometime.
Sure. Yeah, that'd be great.
Can I ask one more question, Glenn, and then I'll get off? But
absolutely, the floor is yours.
So the question is for Tony. We're also, Tony, we're doing an H1N1 study in Connecticut that we've actually consulted with you on, I think, and thank you for that and for your findings. When you talked about the difficulty that local health departments experienced in trying to keep pace with their usual functions and also doing the H1N1 response, Was that burden in part because they were trying to sustain the ICS for an extended period? I wasn't sure about that.
Yeah, there's several different issues going on. One is that, when you go into an ICS structure, you're basically pulling people off their usual jobs.
Right.
So ICS is supposed to be scalable. You're supposed to expand and contract as necessary, but the reality is you're still going to have to pull people off their jobs. The other thing is that when you have someone, say, who is pulled, because H1N1 was not that severe and got really quiet at times, there's this kind of tension about, well, so what are you going to be doing for ICS versus your usual job? Because, you're not in the EOC all day. You might be there, for a morning report and an afternoon checkout or something, and maybe some work group meetings during the day. But in between, you still have your day job to do, right? So there's this big tension. And then there are also all kinds of issues about, say, discipline, right? So let's say someone's not doing their job in ICS. Does the discipline come down through the ICS structure, or do you call their normal supervisor and say, hey, so-and-so is not doing their job, can you talk to them? So you really have two parallel systems, i.e. your normal public health functions going on and your ICS system going on. So all kinds of different issues about how you work between the two.
Right. Thank you.
Excellent questions and comments. I see that we have a question from Julie Marshall coming in over the chat. Julie, do you want to vocalize your question?
Sure. Can you hear me?
Absolutely.
Okay. So this is, I think, in reference to Anthony's presentation, and I think it was slide 14 where it was lessons learned and how the local health jurisdictions had really found this to help them. And I was wondering, one, about the variation across local health jurisdictions in their response, both in kind of being recruited into the process and then their implementation and their reflection. And it seemed like that, as well as your later slide, I think it was 22, about the cyclical process, something like QI, both could be helpful to others of us with colleagues who are still more divided about practice and evaluation of practice and research and how those really belong in many cases together rather than as separate processes, or that you don't measure things the same way or things like that. So hopefully that's clear, but let me know if it's not.
Yeah, so I think one of the things that we benefit from is that we have several different structures within our state. So it's kind of a decentralized state, but Department of Health has this relationship with the different locals, and then our local SACHO, so what's called WSALFO, the Washington State Association of Local Public Health Officials, also is fairly strong. So that there's a lot of overlap between these different structures and the PBRN structures. So the 9 members of the PBRN are among the leaders in the WSALFO and the state structure. So it was fairly easy to move some of the stuff forwards. And then I mentioned there are these kind of 9 different regions for emergency preparedness. So there was a natural connection in the early stages of the study to kind of say, well, you're an emergency response area, so you need to respond to this. And if everyone remembers back to H1N1, everyone didn't know what was going on. They were very open to trying to figure out how they could move forward. So in terms of the first stages of the study, it was not a big problem to get people to buy in, to participate. In terms of where we're going with this, because the funding isn't there, because H1N1 has gone away, I think there's not as much energy around it. We presented this at our state public health conference. I think there's some positive feedback about it. We've tried to bring it up at the SACHO level. So it's really going to be a matter of how we can move this forward. And luckily, Department of Health has agreed to forward this out for feedback. And so we're still playing the, this again is a different area I didn't mention, but there are politics involved, right? So when you're trying to translate or implement something, there's a lot of stuff that goes on behind the scenes, and I think we've been able to convince DOH that this is something that's worthwhile. I'm not sure we've been able to convince them that they need to refine the quality of the handbook and get the feedback and so on. And I think kind of the ace in our pockets is, again, if we cannot get locals to willingly step up, we can kind of work through our influence in the PBRN because we've got 9 local directors on there. We also know who are some of the people very interested in emergency management in the state, so we can kind of try to get them at least on a personal level to do this. But this is a whole area where you're moving from academia into the real world, where trying to make these things happen through personal relationships or politics or whatever, and of course using that whole quality improvement type process of saying, okay, so here's the document. How does it really work for the people in the front lines? And if not, let's revise it, and then let's test it, and let's see whether that worked. And then you just kind of keep making it better before you try and disseminate it and tell everyone that they should use it.
And that's really interesting. And are you, or I'm wondering whether, what are you able to measure, some cost savings that, or something that would lead to like a change in practice, because it's going to have to, probably it supersedes something else, or the idea that it costs something to do this when in fact it seems like it would create efficiencies down the line and improvements in health.
That's
what kind of data do the practitioners really want to be able to be convinced?
So I think cost savings is a very interesting question, because that certainly would help you sell this product, right? To kind of tell people that if you participate in this, then it'll save money. So we need to think a little bit about that. I think it's another area here about sales, right? How do you market this to the locals so that they're willing to participate? I think the reality is all of them have to write emergency plans, right? That's part of the requirements with their contract with the state and their emergency management funding. The challenge for us is to kind of show them that there's added value for this. And I think that for many people, if we are able to link it back to the struggles that they had, and we have been trying to, as I mentioned, the individual reports of this multi-stage H1N1 study were fed back to the constituency as we were going along. So we can always refer back to it and say, remember that report, this is what we found. And our message as we've done the presentations like at statewide meetings and so on is to say, this is really your PBRN. This is really your data. We are helping you identify your needs. And so hopefully that will allow us to move along. But I think that's a great idea for us to think about whether there are financial or other metrics that we can measure. Ultimately, I think if we are able to move this forward, our measures are probably going to be more like process measures, right? So how many people did these? How well did their plans adhere to the recommended guidelines? Did they go through all the steps, right? So there's some process measures which we will have to measure, and then some of the outcomes might be how many people successfully did them, and then other process measures about how did this work during the statewide exercise, and then kind of final measure might be how many of the 35 local health jurisdictions actually did this.
Thank you.
Excellent discussion. Do we have any other questions that folks want to ask of our Washington panelists? Let me take moderator's privilege and a question back to Tina on the workforce study. You mentioned one of the challenges with the comparison group you had originally planned to tee up was the fact that during this period we had the economic downturn and layoffs and reductions in force were happening there that complicate things. I wonder whether that raises a larger issue of the extent to which there are disparities in how you document disparities in hiring practices. Are there disparities in how we implement reductions in force and layoffs or or furloughs, and whether that's any signals from your research about whether that's an area that needs some attention and some research and perhaps similar kinds of QI interventions?
That isn't something that I've looked at. There's been a growing interest in that in the department, and I think that Tracy Hilliard is doing a project, a PBRN funded project that's looking at that to some degree, and we're very interested to see what her outcomes are so that our Human Resources Office can start to build on that. I do know that in the department, there's two interesting pieces of information. One, Public Health Seattle and King County is about 96% unionized, 96% represented employees, and seniority is really the guiding factor in determining who ultimately ends up getting laid off during a RIF. And the other is that I know that as budget developments were taking place this last year and the year before, the department had, as part of the equity project in the last 5 years, developed an equity tool, an equity impact review tool. And that tool was applied to budget decisions to look at not at equity in the staff in terms of who was laid off in the staff, but in terms of impact in the community. I don't know. I wasn't part of those discussions, so I don't really know what changes they might have made in their decision making about budgets and layoffs as a result of the use of that tool. But I expect that we'll start to see that tool be used quite a bit more as decisions are made in the coming years. So I don't, that's a long answer to say I don't really know, but it's definitely something we're starting to look at.
Tracy, I think, is on the call. Tracy, do you want to comment on that?
Yes, thanks. This is Tracy. Can everyone hear me?
Yep.
Yes.
Great. So yes, I'm just beginning my research, and I had a meeting locally in the Public Health Seattle King County HR team where Tina and other folks were present. And that was one of the things that I found as I've been thinking about the research that I'll be conducting actually in not just our local public health department, Public Health Seattle and King County, but also other LHDs across Washington State. And so I do look forward to identifying potentially how this may be playing out in various LHJs across our state and providing perhaps some information about what we can do going forward. I think the thing to think about most clearly so far, as Tina mentioned, is often many of the employees are unionized, and so we might be needing to think about processes in which we can address the differences that we may be seeing about seniority and kind of last hired, first laid off, et cetera. So I'm looking forward to that, and I'm in the process of preparing to launch my interviews in upcoming months.
So just to let everyone know, Tracy is on board as, let me make sure I get this right, it was the new investigator diversity supplement to the project that Betty Beckenmeyer and I did looking at cuts in local health jurisdictions.
That's correct.
Fantastic. Well, that's really exciting, and so we'll look forward to hearing more about what you're finding through that initiative as well. Well, thank you so much to the Washington Public Health PBRN team for stepping us through some of their research in progress. It's really an impressive array of practice-based studies that are happening, and I know that you've just given us some insight into a few of the studies that are underway in the Washington Network, and there are a number of others as well. So it's really an impressive breadth and depth of research that you've got underway there in Washington, and we're all learning from the great work that you're doing. So thank you again for stepping us through some of your research to date. It's probably time for us to, we're down to about the last half an hour or so of our time today, probably time for us to turn to some of our other items on our agenda for today, and more administrative in nature. One of the things that we wanted to do is to just give you a status update on some of the funding opportunities and where we are with these opportunities, both starting with some opportunities that have been made available just through the Public Health PBRN program, and also wanted to highlight some other funding opportunities that are out on the street now that that may be of interest to public health networks. First, just a quick update on where we are with some of our dedicated public health PBRN funding opportunities. Again, a number of our networks applied to be a part of the multi-network research study that the funding announcement that was released earlier in the fall. We had proposals submitted back last month. We have the review process well underway for that particular opportunity, and we hope to have that wrapped up this month and be able to make announcements about funding decisions based on that initiative shortly. So, but that's one that we are obviously very excited about, a chance for us as a program to again test our strategies for implementing a study across multiple PBRN networks and learning from that opportunity. So that's underway. Stay tuned for announcements about funding decisions from that. And again, thank you for those who applied for that opportunity. We also had a late-breaking funding opportunity that was announced last month as well, the opportunity for networks to apply for junior investigator awards to expand the diversity of PBRN research teams. And this was an opportunity to apply for a small amount of funding to support a pre-doctoral or post-doctoral research investigator from an underrepresented background, provide them with some support and an opportunity to work with an ongoing public health PBRN research study and to receive some mentorship and experience through the PBRN. And that applications closed earlier this week for that. Again, thanks to those who applied for that opportunity. We'll keep you posted on the review process and funding decisions on that as well. That particular funding opportunity, we're trying to use a fairly rapid cycle review process, so we hope to have information on the status of those applications quite brief time in the next couple of weeks. We also wanted to remind you that we are open for receiving proposals for the PBRN Quick Strike Research Funds, the Quick Strike projects. We heard about at least one of the Quick Strike projects that Washington has been implementing. And so as we have in years past, we're open for receiving proposals for Quick Strike projects now. I think at this stage, we've got one Quick Strike application in hand that we've had for a little while now from the Wisconsin Public Health PBRN. And I want to say, Wisconsin, we apologize for the delay in getting back to you on that. We hope to be able to have some feedback for the Wisconsin team on their Quick Strike application actually as early as tomorrow. The reason for the delay is that you happen to propose a topic that fits within a larger initiative that the Robert Johnson Foundation is planning currently, and so the foundation asked for an opportunity to kind of circulate your idea among the team that is planning the initiative, the related initiative at the foundation, and so they asked me to have until tomorrow to finish their review process. Normally, our Quick Strike proposals don't have this multi-layer review at the foundation, but because of the nature of the very interesting topic that you pitched with Wisconsin, that happened to be in line with a larger RWJ initiative, they asked for a little time there. So So Wisconsin, we hope to have you some feedback and information about your Quick Strike application shortly. I know I've talked to some other folks and some other PBRNs about possible Quick Strike ideas, so I know there are some ideas that are percolating, but just to remind folks that we are open for business in terms of being able to receive and review Quick Strike research proposals. So send us your ideas, send us your proposals. If you want to talk about your idea ahead of time with one of us, we're always glad to do that at the coordinating center. So let us know, and we're glad to do that. In terms of some of these other funding opportunities that I've got up here on this slide, these have been featured in recent PBRN newsletters, but just to highlight some of them, the Foundation is continuing its support and funding for implementation of QI projects in public health, and there is a current opportunity that the Foundation put out last month that I think closes later this month, related to applications from public health agencies to apply for funding to support QI implementation. So again, if you're interested in that, you may want to check your newsletter, one of the past newsletters where we've included specific links on how to access that particular funding opportunity from the Foundation, or just send us an email to the Public Health PBRN email account, and we can steer you toward that. There are also a number of other funding opportunities that are available from other funders, especially federal health-related funding agencies right now that are potentially of interest to public health PBRNs and are potentially in line with research activities and research interests that we know are percolating within the public health PBRNs. These last couple of bullets show a few of them that are more recently announced federal funding opportunities. One of the most recent opportunities from the NIH Common Fund relates to research around studying healthcare delivery and financing pilot programs and demonstration programs, some of which certainly may involve public health agencies in these pilot and demonstration programs. So if your network is involved or interested in or has members who are involved in implementing healthcare delivery system innovations like patient-centered medical homes or accountable care organization or care coordination, disease prevention, and disease management kinds of interventions that are being implemented as part of delivery system innovations, this particular funding opportunity that provides funding for research to study the implementation and the impact of those kind of demonstration programs might be of interest to you. And the Common Fund opportunities are, I think, especially are especially of interest because they allow, unlike a lot of other NIH funding mechanisms that are targeted to specific institutes and therefore specific disease areas, the NIH Common Fund is designed to support research that is cross-cutting in nature, that looks at multiple disease areas or risk factor and prevention areas, and in particular research that looks at kind of delivery system types of interventions, which we know many of the public health PBRNs are interested in looking at from a public health delivery system or a prevention delivery system standpoint. So take a look at that if that might be of interest. One of the large new sources of federal funding, both for applied evaluation and research and for implementation of new delivery system kind of innovations, is the CMS, what we call the CMS Innovation Center, the Center for Medicare and Medicaid Services Innovation Center that was created by the Affordable Care Act last year. That Innovation Center is pushing out a couple of $1 billion in new in funding for new healthcare delivery system innovations. And so again, we featured the call for applications for that, for the Innovation Center in recent newsletters. So this is a big new source of support, primarily funding to actually implement new stuff as opposed to just conduct research, but funding to actually implement new ways of delivering services. And certainly medical care treatment services are high on the list, but not exclusively. The Innovation Center has a population health branch within it, and that population health branch is interested in funding new ways of delivering prevention and population health, not just medical treatment. So I encourage you to take a look at the announcements that are coming out of the CMS Innovation Center to see if they might be of interest. And again, those can be used for actually implementing new service delivery models, new public health and prevention approaches, not just for funding research and evaluation around those approaches. There's a two-tiered, or kind of two different time frames that are important with the CMS Innovation Center funding. The first deadline for applications is actually coming up, I think, at the end of this month. But for those of you who missed that deadline, or where that deadline is unrealistic, there will be a deadline, a second deadline for applications in the spring. CMS hasn't, I don't think they've nailed down the exact date for that, but sometime in the spring, probably March or April, for applying for funding from this Innovation Center as well. And I've been in conversations with the folks at the population health branch within this Innovation Center. They're very interested in receiving proposals that involve delivery of public health and prevention services as part of healthcare delivery system innovation, and are especially interested in receiving proposals during the spring deadline. So definitely take a look at that opportunity and see whether it might fit with some of the work and some of the interests that are within your PBRNs. These other couple of funding opportunities here. NSF, the National Science Foundation, has a renewed interest in prevention and in public health, and particularly in looking at system-level solutions for prevention and public health, and technological solutions for prevention and public health. This announcement on smart health and well-being is one of the more recent funding announcements out of NSF. I know that some of our PBRN networks are interested in looking at the application of technology, of using EMR systems or health information exchange to promote prevention and public health delivery, or looking at mobile applications, so-called mHealth applications in public health and prevention. And so some of these NSF funding opportunities might be relevant to you all who are exploring those opportunities, or looking at ways of incorporating public health informatics into this work. That funding opportunity might be relevant. And then NIH continues to put out funding opportunities under its system science and health research agenda. So for those of you who are using system science approaches in your public health PBRN work, whether that's network analysis, or other ways of looking at the public health delivery system as a complex and adaptive system, these NIH funding opportunities that are coming out under the System Science and Health Research Initiative might be of interest to you. These are just a few of the relatively new funding opportunities that are out there. Again, we try to feature these regularly in the newsletters, so keep your eyes peeled for these. And again, if we can be of help at the Coordinating Center in helping you pursue these opportunities, helping you brainstorm perhaps about how to position for them, or helping to build multi-network consortia, that might involve multiple networks coming together to pursue some of these opportunities, let us know. We're glad to help you put together, glad to brainstorm or help put together teams to go after these kind of funding opportunities. Let me stop and see if there's any questions that folks want to raise on those or other funding opportunities.
Glenn, this is Julie. I thought I read in the CMS Innovation Challenge, buried somewhere, that the second deadline would be in June.
Oh, maybe so. I may have missed that. That might be the case. Should probably go back and look at that. But there are two submission deadlines, and so if you're not going to make this January deadline, just yeah, recognize there's still be another time to apply. Thanks for pointing that out, Julie. We'll go back and take a look at that. Other questions and thoughts about funding? I think I've mentioned in the past the fact that, and we certainly announced this back at the Keeneland conference last spring, that there will be a new funding opportunity coming out of the RWJ Foundation to fund natural experiments, research around natural experiments in public health practice and public health system change. That that funding opportunity is still moving down the pipeline. It's kind of been, the timeline has been pushed back a little bit on that, but we expect to have an open call for proposals out for in that arena very shortly, in the near term, and so we'll certainly make sure to get the word out to our public health PBRNs when that funding opportunity is available. Because again, I think PBRNs are a particularly good vehicle for launching studies of natural experiments when there's a change in a policy or a delivery system or a organizational change, and you've got the opportunity to set up a natural experiment to study the effects of those changes on public health delivery. PBRNs are particularly good vehicles for doing that, so that is an opportunity that's still out there on the horizon that should be announced in the relatively near term.
Glenn, this is Laura Hitchcock. Was that going to be specific to PBRNs, or is it a broader PHSSR community proposal?
Yeah, it is going to be a broader and open call, coming out of the larger PHSSR enterprise at the foundation. So it's not restricted to just the PBRNs, but certainly the PBRNs are, I think, well positioned for that opportunity.
Thank you.
Okay, moving along, and we are drawing close on time here. We did want to talk a little bit about, touch base on some of the research dissemination opportunities that are out there on the horizon. Several networks submitted papers for this theme issue of the American Journal of Preventive Medicine on PBRN-related research. That process is moving forward. We're still kind of in a journal review stage for those papers, but we hope to have some news for those networks who submitted to that theme issue shortly. Part of the delay has been we're working with the American Journal of Preventive Medicine on two different issues right now. We have this theme issue, and we also have a larger special issue devoted to the new PHSSR research agenda and related activities, and so that first special issue is kind of in front of us in the queue at the American Journal of Preventive Medicine, but we're nearing completion on that issue, and so we should be able to move forward and hear some news back from the journal on our PBRN theme issue, our cluster of papers related to PBRN studies very shortly, so stay tuned on that. We also announced last month the fact that we're putting together a special issue of the Journal of Public Health Management and Practice devoted to advances in PHSSR, and we have invited paper, and that special issue is largely going to be comprised of invited papers. We have sent out invitations to a number of people within the public health PBRNs that expressed interest in this opportunity, and so a number of you have already received an invitation from us to contribute a paper to that journal. If you haven't received an invitation and you've got a really good idea, you've got some results back from a PBRN study that you think would be a really good fit for this journal, it's not too late. If you want to send us a quick email to the Public Health PBRN email account, and if you think you can get a paper to us submitted to this journal by March 1, let us know, and we still may have some room in that special issue for you. We do have a March 1 deadline for submissions. That is a hard and fast deadline, so I know that's coming up quick. But that's moving forward, and we're really excited about that issue. This is going to be the November 2012 issue of the journal that we released just in advance of the APHA annual meeting. It's going to be really promoted and featured at the APHA annual meeting. So it will be a good, I think, a good vehicle for getting the word out about PHSSR studies and advances what we're learning through collectively our work in PHSSR, certainly including the public health PBRN research. That's moving forward. The REACT podcast, Research to Action podcast. This is a new dissemination vehicle that we're launching through the Public Health PBRN program. We've mentioned it in the past and have featured it in the newsletter. We are teed up to really start implementing these podcasts. And so Dr. Paul Halverson, who's the State Health Commissioner in Arkansas, has agreed to be the host of these podcasts. What we want to do is, as you've got studies that are producing findings through your PBRN work, let us know, and we'd like to set up a podcast opportunity where basically we'll schedule a time when Dr. Halverson will link up with one or more of investigators, leaders from your PBRN, to talk about the findings from one of your PBRN studies, and really to hone in on the practice and policy implications of your study. And so Halverson is really going to kind of query you and your team about not only findings, but what it means for practice and policy. What should we be doing differently in practice and policy, perhaps as a result of your findings? We'll record those, and Halverson's all set up with the recording equipment now to do these. And we'll feature them on the website, we'll feature them in newsletters, and we'll feature them in some other exciting dissemination vehicles that we're teeing up through the PBRN program. So I think we've been in conversations with Laura in the Washington Network about perhaps starting with a podcast with one of the great Washington PBRN studies that we just heard about. But if you've got others in the PBRN community have ideas, shoot us an email, and we'll get to work on scheduling that. I'm going to be meeting with Halverson next week to get these first slate of podcasts teed up and going. So let us know if you've got a study that's ready to be featured. These are going to be short. These are going to be 4 to 5 minute interviews that Halverson will be doing for us. We also have there's been a flurry of activity around abstract submissions for a number of the national public health research and public health professional meetings that are coming up. And we had the abstracts for the Keeneland conference that were due a week or so ago, and then we had a number of public health PBRN abstracts that went in for that. We just earlier this week, the abstracts for the Academy Health Annual Research Meeting, abstracts were due for that meeting, and then we had a number of public health PBRN abstracts that went in for that, and at least one panel proposal that went in for that. There's now an open call for both paper and panel submissions for the Academy Health Special Interest Group in Public Health Services and Systems Research. The deadline for those abstracts, I believe, is February 15th. And so keep that on your radar if there's an interest in putting together a panel submission for that meeting of the Academy Health Interest Group. And if you want us at the Coordinating Center to help organize that, let us know. Or if you want help, with writing an abstract, et cetera, feel free to let us know. Shoot us an email, and we're glad to do that. Also, the NACCHO annual meeting, deadline for abstract submissions for that meeting was just extended. The deadline was originally this week sometime. It was extended, I think, to the 24th of January, which is good news for those of you who may want to make a submission but haven't had a chance to do that. I know that I've been working with a few of you under Justine Hyde's leadership and Bill Livingood's leadership. There's an effort to put together a panel submission for NACCHO around several PBRN studies that relate to looking at regionalization and shared services, so that's going forward. I know Betty Beckmeyer and the Washington PBRN was putting together some work as well around the FAST study and related research within PBRNs. So again, let us know if we can help. Be helpful on any of those. The call for abstracts for APHA is still open, but we'll be closing typically in early January. There's variable deadlines depending on what section you're submitting to within APHA. We definitely would love to get one or a couple of panel submissions together for the APHA annual meeting. So if you've got an idea for a panel or a session around a theme that potentially involves multiple PBRN networks, if you want our help in putting together a panel submission for APHA, let us know. That's another very good meeting. I think it's scheduled. APHA is going to be in San Francisco this year. NACCHO is going to be in Los Angeles. Academy Health is going to be in Orlando. So great places to travel and present PBRN research. Quickly, these other couple of dissemination opportunities you'll be hearing more about in the future. We are launching with RWJ support a new open access journal that is going to be called Frontiers in Public Health Services and Systems Research that we're going to be launching through an open access platform through the Berkeley Electronic Press platform. So this is very exciting. Our intent is that this will, unlike a lot of our wonderful existing peer-reviewed public health journals, this is going to be designed to be open access, so hopefully a lot more accessible to public health practitioners who don't have subscriptions to these high-priced commercial journals. And also our intent is to be very rapid cycle with regard to both the submissions and the dissemination of articles that are submitted and published through this new journal. So our model is kind of the morbidity and mortality weekly report of the CDC journal. It is very rapid cycle, features short articles that kind of focus on preliminary and emerging findings from ongoing research. That is very much going to be our intention with Frontiers. We also have developed this journal. We're developing it in partnership with the American Journal of Preventive Medicine. They're going to help us launch and support and disseminate this particular journal, and also through a special arrangement with AJPM. Short articles that are featured in Frontiers are going to be considered for the publication of the full scientific article will receive special consideration for publication in the American Journal of Preventive Medicine. So it's a nice collaboration that we've worked out with AJPM for this vehicle. We're just letting you know about this now. We're going to obviously be putting out more information about the journal and its launch later this spring. We hope to have the first issue of the journal be launched to coincide with the Keeneland Conference on PHSSR this upcoming April. So stay tuned for more information about that. We're also working on a PHSSR methods book as well that will be another, an actual textbook that will be another way of disseminating some of the work and some of our learnings about methods in PHSSR as well. So those are just a few quick updates on dissemination opportunities that are available to our colleagues in the public health PBRNs. In our last couple minutes here, we do need to put together a schedule for our 2012 monthly webinar presentations for networks that want to be featured and that are willing to kind of have some of their research and practice featured during the first part of these monthly meetings. We've proposed the following schedule, just kind of made random assignments for our 2012 sequence of meetings that you see here. And we'll also be emailing the schedule out to you. Let us know if there's a problem with where we've slotted your network in terms of our monthly sequence of webinars. But again, this would be the month where your network would have the opportunity to take the first 30, 45 minutes of our meeting to showcase some research in progress from your network. That component of our meeting has proven to be very popular. I know certainly I've got a lot out of these sessions, and we've heard from a number of you that this is very useful. So we want to line up our 2012 schedule with these monthly research in progress updates, and this is what we've proposed here. But let us know if this doesn't work out. You can certainly swap with each other, swap months if that if we put you on a month that is not going to work well with your network. And then finally, I know we're at a time of year now where some of you have your funded grants from the Johnson Foundation are coming up against either annual reporting deadlines or final reporting deadlines. Some of your networks are finishing up projects, finishing up your initial base grants, for example, and now you've got reports that are due back to the foundation. Just a reminder of the guidelines that are available from the Robert Wood Johnson Foundation about how to put together those narrative reports and the financial reports. I've put the links up to those guidelines here on the slide. We'll also put these in the newsletter as well. The guidelines are fairly self-explanatory around what your narrative report should look like, what your financial report should look like, and also guidelines around how to submit products from your research to the foundation using their electronic submission standards. Obviously, if you've got any questions about that, you can feel free to let us know. Send an email to the Public Health PBRN Coordinating Center. We're glad to help you with that. We're also glad to review, if you want us to review early drafts of your reports, give you feedback. We're glad to do that as well and help in any way we can. Remember that if you've received a QI, a quick strike research grant, either a standard quick strike or one of the QI quick strike grants from last year, those are awards that we make from our coordinating center directly to you, so you don't have to report back using these channels. What we ask for reporting in terms of quick strike projects is just to send us to the coordinating center, send us your research products from the quick strike grant. That will be your final report. Send us your manuscript, send us your research brief, etc. The product or products from your quick strike grants. That's all we need in terms of a report from quick strike projects. But otherwise, if you're reporting back on grants that you're receiving directly from the foundation, you do need to follow these reporting guidelines, and also make sure to always copy the National Coordinating Center when you send in these reports to the foundation, so that we can keep track of your great progress as well. So with that, I think we are out of time for today. Thank you all for participating in the call here. Again, thanks to our colleagues in Washington for hosting the first part of our meeting. Any questions or comments that come up based on today's call, let us know. Shoot us an email. We did record our session today, so for those of you who might have colleagues who missed the session but want to hear about the great work happening in Washington, we'll post the link to that recording on our website, and you can get access to that after the fact. And Happy New Year, everybody, and thanks for the great work that you're doing in the Public Health PBRNs. We'll sign off for now.
Thanks, Glenn.
Thank you so much.